afternoon, everyone. My manager has an adage that she always puts in front of me when I'm doing presentations, and it's be brief, be quick, be gone. Okay? So I will attempt to do that today, because I know my presentation was just before a scheduled comfort break. So just hang on there a little bit, guys. I won't go on too long. So what I wanted to talk to you about today is the human factors in patient deterioration. We've had three presentations there, looking at all of those elements that we bring together to measure patient deterioration, looking at early warning scores, etc. Okay? So why is it important? Okay? Well, there's a whole wealth of information out there that shows us that unrecognized clinical deterioration of patients can lead to adverse events, and that's what we want to avoid. Okay? Early warning, stopping people deteriorating, stops people going into ITU. It's just common sense, logic to me. So why is all this work going on? Why are people looking at it in such detail? There's a trust in London, major trust, that teaches everybody from healthcare assistants through to the highest consultants. They have a £70 million a year training budget, and all of their clinical staff are educated and trained as a minimum in basic life support. Great aim, good achievement. They have a relatively low level of cardiac arrest. But if you look at the data and the statistics, it says how many of those clinical members of staff actually use those skills in their whole career. And the figures show us across the UK, it's about 5.2% of clinicians actually use those skills. Yet there's a huge emphasis on training those people to respond to a cardiac arrest. And the premise of my discussion for the next sort of quarter, an hour, 20 minutes is to say, why don't we take some of that budget and put it and focus it on educating people to stop cardiac arrests happening, to look at patient deterioration and give people the skills to actually highlight that and stop it happening. So is there a real need? Well, there definitely is. These are global figures, but they can be very easily extrapolated to the UK and NHS. So 440,000 deaths in the US from preventable medical emergencies. We know that about 85% of deaths in most hospitals occur outside of the general ICU, and John's already alluded to the fact that the ICU is quite a safe place to be. 8 to 12% of hospitalizations experience a medical error or a nursing error of some description. Okay? And 66% of those cardiac arrests that we're all highly trained to respond to show abnormal signs about 6 to 8 hours prior to that. But physicians, those people that can respond and treat, okay, are only notified about 25% of the time. So why does that happen? Because we all got the same aims in healthcare. So compliance is a big problem, the human factor. We can add education in, but if we don't focus it in the right place, we end up treating people to respond to emergencies rather than preventing them. So the nice recommendations is that observation should be monitored at least 12 hourly, and that's across all patients in an acute hospital, okay? And that frequency of observation should increase if we detect an abnormality. Okay? And we know, and we keep reiterating that an inadequate response to that deterioration, okay, is one of the most common causes of these critical incidents. So a couple of big studies that were done, so one in the whole of Scotland, it's probably akin to the one that John mentioned actually. It shows that 64% of patients in acute hospitals in Scotland have at least one or more of their observations simply not done. Okay? So how can we respond to that information if we're not actually doing them? Further to that, a South of England study looked at overnight, what happens overnight when we've got less trained staff on, less experience on potentially, more of a skeleton crew on there, okay? So of nearly 1 million episodes of vital signs observation, okay, overnight, only 13% were done overnight. And you would expect on a 24-hour continuum, it would be roughly 50-50, wouldn't it? Okay. And even more concerning is that those patients within that group who already had an early warning score that was elevated, okay, prior to that measurement time at 11 o'clock, only 57% of those already identified sick patients actually had any further observations done overnight. So what good is scoring a patient? What benefit can we get from all of this data if we're not educating people right at the forefront to put that information in? And our colleagues in the Society for Critical Care Medicine said that one of the things that we need to think about is simply apply technologies and skills that have been successfully utilised in other fields, such as finance or aviation. And data that's available, okay, we need to grab hold of that, okay? Make sure the data's accurate, make sure that input's been put in. Okay? So, for example, Storm Ciara over the weekend, did anybody see the footage of those airplanes coming down to land at Manchester and having to do go-arounds, okay? The pilots have a system, okay? When they're concerned, they alert the cabin crew, and you'll hear that, cabin crew to the flight deck, please. When those people come into the flight deck, they have a process. I have a safety briefing for you. Are you ready to receive it? And the response should be, yes, I understand you have a safety briefing. I'm ready to receive it. And then the information is passed through. I would ask every single person in the room, and I think you would all have an episode in your career where a degree of frustration comes in because that person you're talking to doesn't seem to be responding to what you're saying. Okay? And if that's related to clinical situations, then there's a big risk from that. So all of that's worrying news, worrying information. So what have we done as a collective, you know, across commercial business as well as the National Health Service, okay? We've put an awful lot of effort into putting early warning scores in, okay? News 1, News 2, there's lots of different systems out there to score our patients, lots of different information to tell us what to do when the score's high or the score's low. Matt's mentioned about the ideal would be to have our general practitioner colleagues score them right at the beginning of that patient journey and pass it all the way through. And that's the ideal there. So early warning scores are rolling out, and I'm really, really happy to hear that there's some funding coming behind that to make it more of a national concept rather than a local one. But there's a problem with early warning scores. And the problem with early warning scores is, apologies for repeating the slide, is compliance. If we don't input the data into a scoring mechanism, that score is irrelevant at the other end. If we don't respond to the score afterwards and don't do anything and don't put action in, then that early warning score just becomes a simple paper exercise. And when you look at some of the audits and the papers that are out there about what happens with early warning score, there's some great big happy ticks to say we've got almost 100% compliance in recording our early warning scores. So we give ourselves a round of applause or a pat on the back. But do we really look at the behaviour and what happens afterwards? So perceptions and barriers. So if we look at some of the more qualitative audits that have been done and some of those surveys, it shows that our staff are responding to say that they don't attach the importance to those vital signs. There's too many other pressures on them. I guarantee almost if you go to a general ward environment, those qualified nurses on the ward have pressures that don't include vital signs. The discharge liaison officers coming around to see me to get these patients out of bed. Okay? I've got a waiting list for patients to go into theatre. I have no beds for them. So their whole focus is drifted away from those vital areas. It's often healthcare assistants that record those observations. Do they have the necessary depth of knowledge and skills to interpret them immediately and escalate that process? The key thing that comes back is everybody knows, I mean, it comes from neonatology, you know, if the baby doesn't sleep, it doesn't get better. So it's better to let the patient rest than disturbing them, okay? They're nice and fast asleep, let's not wake them up to do their blood pressure. And then our relationship with the medical staff. I have a cardiothoracic background. And I don't know, I'll share with you, the ABC of cardiac surgery is accuse, blame, and criticize, okay? I'm sure everybody that laughed then has met a cardiac surgeon, okay? But the key thing is that if we don't have that working relationship, that mutual trust and understanding, then our communication breaks down. And we end up with a lack of ownership. There might be some abnormal observations, but nobody's doing anything with them. And there's different languages used by nurses and physicians. There's a lot of evidence out there to support that. Nurses tend, if you ask a doctor and a nurse to tell you how much pain that patient's in, most doctors will rely on a pain score and what the prescription is to follow that. Whereas the nurse will probably give you a little bit softer information about how the patient's feeling, whether they're agitated, etc. So there's a different language that we have to talk about. And I guess what I'm coming round to is that those people at the coalface of healthcare are kind of not doing their job properly. Okay? They're not recording those observations. So there's a lot of evidence to suggest that. And even when they do, are they interpreting them properly? So education and training are critical in preventing patient deterioration. Okay? A couple of our speakers have already alluded to the most important vital sign is respiratory rate. How easy is it to record a respiratory rate? When you're bare below the elbows, so you have no watch on. Infection control says you can't lean across a patient with a dangly thing, so you have no fob watch anymore. And it's a real faux pas for a nurse to be seen walking around with their smartphone in a clinical environment. Okay? So they don't record the vital signs appropriately. They'll perhaps record a respiratory rate for 15 seconds or so. 60% of people in a survey that was done said that oxygen saturations was the best way to evaluate respiratory function or respiratory deterioration. Okay? That's a recording taken, and it's in relation to the respiratory rate. The respiratory rate will change quicker than you'll see your saturation change. 57% of this survey showed that the patient perceived that blood pressure is the first indication of going down. Okay? We've already crashed the car by that point. And then, going back to my initial earlier point, 27.4% only make that quick estimate, okay? And I think if I said to you all, let's just sit and count for a minute, you'd all be bored by about 30 seconds, okay? So we have to go back to that. So education is critical. We need to go back to that earlier point and address those issues and understand that. There's a thing called, I don't know whether you've come across, it's called the Aberline paradox, okay? Where we all go along together. It's part of human behavioral science. The Aberline paradox tells us that if the fire alarm goes off in here, however sophisticated that fire alerting system is, most of us will think it's likely to be a fault or a test, okay? And there'll be very few people in the room will actually say, well, we really ought to check, because there's a consensus that we can't smell smoke, there's no heat, you know, it's probably a fault in the system, okay? And the Aberline paradox drives us towards that, okay? So if we're all accepting poor measurements, poor performance, but we're comfortable within that, then we have to break those barriers. So how do we do it? A formalised education programme, not focused on dealing with cardiac arrest, but dealing with patient deterioration. Teach people again the anatomy, the physiology, what is cardiac output, what is respiratory, how does it work? And look at 3 key areas. If there isn't any observations taken when you assess this, look at why. Do we have the equipment? Is it working? Okay. Do we know how to use it? Okay. Have we got the time to do those observations? Okay. Do we understand why they're important? If we don't understand them, okay, we can't interpret trend results. Has everybody been taught in clinical practice the seagull sign? You really know what I'm on about, okay? So when you write an observation down, the blood pressure, there's a little tick mark for the top, for the systolic, okay? And there's a little blob on there for the heart rate, okay? If you think of the tick mark as the seagull and the blob as its poo, okay? If the poo is above the bird, that's abnormal, isn't it? Okay? So on an observation sign, if you see the seagull sign, say, but you need to know that. You need to be able to interpret that and say that it's wrong. Okay? You like the seagull sign then, okay? And why don't we respond to it? Why don't we trigger, okay? Have we got the observations? Have they actually been done, okay? Can we develop a diagnosis from that? If not, are we able to escalate it? Okay? Poorly constructed communication to enable people to interpret that. It's that evidence, that information that we give. So we should put communication plans in and processes in that everybody understands. Okay? We do the obs, they get interpreted by somebody who knows what they're doing. We communicate that to the rest of the team, get some medical assistance, start the treatment, and then review again. It's logic, but we don't do it as often as we should. When we're communicating, we should have a structure. This is what this whole conference is about. It's a safety thing. Identify yourself. If you get a phone call from somebody on ward 3, I've got a poorly patient, there's no context. So you would say, I'm the charge nurse or I'm the staff nurse. It adds weight, it adds gravitas or context to it. What's the situation? It's not a little old lady who needs a drip. This lady needs a drip because she's got antibiotics at 6 o'clock in the morning, there's no hurry, or she's got no blood pressure, she needs it now. So ISBAR is an internationally recognized communication structure that allows us to talk in a common language. Then we come back to the documentation, and this is really, I'm going to skim over it, because this is echoing what our previous speakers have said. We have to have a way of doing this. So this is the little Philips bit that I'll put in. Okay, Philips is an innovation company, has lots of products, a whole portfolio for patient monitoring, and we would like to partner up with our customers. So we've developed an education program that we add in to those monitoring solutions. We recognize it's not just technology. Okay? So we will help customers work through these plans, okay, to make sure that the OBS are done, the early warning scores are appropriate, and that we respond to them in a timely manner, because everybody knows and everybody's focused. So does it work? Or am I just, waxing lyrical here? So one of our customers recently, Ysbyty Gwynedd General Hospital in Bangor in Wales, put in a technology system that did automated early warning score linked to a Guardian artificial intelligence system that gives early warning scores, puts it on dashboards on the wall, a technology solution. But we also went in and did an education program with the staff, so they all understood what these early warning scores, so it's in their frontal lobe. And in the first year, we had a 35% reduction in serious events, 86% reduction in cardiac arrests. Yes, okay? Let's treat the patient before the arrest. 24% reduction in ICU admissions. And those patients that did get admitted to ITU had a 66% reduction in their ICU mortality, just by focusing people on those early warning scores and that interpretation. And if we step back a little bit and put that into a bigger picture and look at addressing those quadruple aims that we're all driving towards, okay, we can improve the health providers' working life, because nobody likes to be involved in an adverse incident. All of the litigation that's getting bigger and bigger and going on with that, so we can reduce that. Okay. Boosting health outcomes. Well, we've got rid of 86% cardiac arrest. That's a big tick in my book. Okay. I was really good at cardiac arrest. I used to do restenotomies when I was working in cardiac ITU, but I used to hate them. Okay, because to me it was almost a failure to let that patient get to that point. Okay. Enrich the patient and the family experience. Okay, the patient feels safer in a general care unit. Unfortunately, the statistics tell us, despite Storm Ciara, that you're actually safer in an aeroplane than you are at a general hospital. Okay. And then we've looked at the cost and improved those financials. Been able to show reduction in Apache scores of patients going into ITU, because it's a patient that's got in an early deterioration phase rather than a complete car crash. A big drop in the ICU admission rate, and some of our critical care colleagues have fed back to us and said they can control ITU really well. What terrifies them is what's happening outside, because they can't control that. Okay? And overall, a use of an early warning system can reduce length of stay, but only if it's added into an education program to really focus people on that. So just to draw to a close then, my key messages today is that to really reinforce that communication failures account for the overwhelming majority of unanticipated adverse events in patients. Okay? Medical care these days and nursing care is really complex, and even with the most skilled, experienced and highly motivated teams of individuals, there will be mistakes. Okay? So if we can educate teams specifically to put teamwork, communication pathways in, very much focused on patient deterioration, okay, we will change the outcomes and the consequences. Put something in like ESPAR, something similar, okay, so we understand that terminology, okay, and address that difference in communication styles between nurses and physicians and others. Let's make that standardized so that we all understand each other. And then hopefully what we can do then is we can change that outcomes of those patients, because the figures that we've been shared with by my colleagues on the panel there are really alarming. That now 150 deaths in each trust that needn't happen. Food for thought. Thank you very much for your time.